Hello, this is my first experience with evaluation at an inpatient unit. The patient was a 24-year-old female. She was currently 16 weeks pregnant when she arrived at crisis. She was brought in by her partner, to whom she had expressed suicidal ideation. Upon interviewing, we discovered that patient is also using marijuana to self-treat her nausea and vomiting. Patient was alert and oriented. She was actually very pleasant. She reported that she's been experiencing increased symptoms of anxiety. She has past history of major depressive disorder. Anxiety was situational, mostly related to her new pregnancy, which was a planned pregnancy. Her living situation, due to financial constraints, was going to change. Her partner and her were going to move with her partner's family because they can no longer pay the rent or afford to pay the rent. Her partner has a job and patient is unemployed. Patient expressed a lot of guilt associated with the fact that she is unable to financially contribute, and which is leading to increased symptoms of depression, and so much so that she is unable to complete her activities of daily living as well. Cannabinoid use was associated with self-treating her nausea and vomiting. Patient reported hyperemesis gravidarum, for which she is being treated by her OB with what we call Bongesta. It is a medication that has vitamin B6, which is also the first-line antiemetic in terms of pregnancy, emesis during pregnancy. So there was some counseling that we did to the patient on the use of marijuana during pregnancy, risks, and there's not a whole lot of quantified research or valid research that can say that marijuana, what kind of risks marijuana hold, but it's best to avoid it. Patient was agreeable to increasing her current dose of sertraline from 100 milligrams to 150 milligrams daily. We did add some hydroxyzine PRN, 50 milligrams, to kind of help her get some sleep and calm her anxiety. Patient was agreeable to this plan. We also educated her that there are not a whole lot of meds available that can be prescribed during pregnancy, and therefore we are limited with options. So that's that. Patient is agreeable to continuing therapy even outside of after she's being discharged from inpatient stay. Patient says that she enjoys therapy, she gets great benefit out of it, and she would like to be referred to a therapist. So the plan is in place. We will monitor her for 24 hours to see how the new dose increase with Zoloft as well as new medication add-on with hydroxyzine do, and if we are able to control her nausea vomiting with Zofran in addition to Bongesta.